Good morning, Assalamu alaikum, distinguished speakers and my guests and fellow native Rohingyas. As we all know that experts and speakers have been talking on going genocide within in Myanmar against Rohingyas. So not only that, there are global institutions like international state crimes initiatives, Human Rights Watch, Fortify Rights, Queen Mary University of London, Yale University Law Clinic, University of Washington Law School. They have visited our Rakhine state in Myanmar, and all their fingers with their informations, facts and figures lead to the conclusion that Burma or Myanmar regime is consistently commissioning crimes against Rohingya humanities, genocide on Rohingya. There are many ways how to extermination phase can be materialized. Now, I would like to talk on some consequences on healthcare denial still being used as genocidal tool in Arakan against Rohingya. MSF International is one of the largest and the main healthcare providers to Rohingya in Arakan state. Suspension in 2014 and later with increasing restrictions from authorities, their activities and projects have been significantly affected. Public health of Rohingya living in IDP camps and open prisons being worsened. Restrictions of movement on Rohingya is another made obstacle that 90% of the population become inaccessible to formal health care. The majority of deaths in children under 5 each year are avoidable mortality, that is, deaths due to illness such as malaria, diarrhea, measles, malnutrition, or respiratory tract infection, which can be generally prevented or inexpensively treated. Here is an image which is a very disturbing. She is a lady, Anjum Begum, who lived in Situay IDP camp, died this year in March due to 2 years of suffering from mouth and jaw cancer. So when we are talking about the genocide tool used by the Burmese regime, we Rohingyas, a group called Doctors for Humanity, has witnessed this denial of health care. Doctors for Humanity is a group of Rohingya doctors living worldwide and supported by like-minded Rohingya volunteers working association with Mayu Aid Team for Humanity. It was formed when MSF was driven out of Rakhine State in 2014 to help Rohingya with advice and consultations. We have covered patients in Situay, Paktau, Mrauk U, Chokto, Minbya, and around 15,000 cases have been consulted. Most of our cases were labor complications and liver cirrhosis till today. Rohingya in Arakan, particularly in IDP camps, have limited access to food, and that comes to starvation is widespread. Adequate frequencies of meal and basic nutritious food, which are important for proper human nourishment, is non-existent in IDP camps. Recent information showed that they are relying on only 1 meal per day, which is also mostly single ingredient meal, which is rice and water. Malnutrition and anemia is very common among under 5 years age of Rohingya children all over IDP camps. Severely malnourished children number drastically increased recently as per European Union agency, and it could be expected more in 2016. According to UNICEF, malnourished children are 9 times prone to death than normal children. Reasons leading to malnutrition, anemia, intrauterine growth retardation are directly proportional to government blockade on AIDS, restriction on NGOs, and of course, expulsion of MSF from Rakhine State. I will show you some pictures of just recently from this year. This is a very malnourished child in IDP camp Sitwe, Rakhine State. There's another malnourished child in Sitwe, Rakhine State. Rohingya have very limited access to emergency healthcare service. Freedom of movement is severely restricted, so reaching to medical facilities is unimaginable. Alarming rate of maternal death are recorded since 2012 among Rohingya pregnant women. Due to delay reaching to clinic, hospital after passing many bureaucracy, many pregnant women were returned either dead with their inborn child or with their child. Medical negligence internationally is widespread due to obsessive racial hatred. One incident happened last month. There were 4 ladies admitted in one-day normal pregnant women for normal deliveries, and none of them was survived. No death certificates were issued to cover up all the mistreatment done by medical staff. So this is the victim from this incident, and as I've said, that she was normal and then she died there. There's another, she was late 30s in Pakto IDP camp, died in 2014 in April, and the cause of the death allegedly by deliberate medical negligences. This is another recent one. I think last week, Bashir Ahmad, Rohingya man, was attacked by Rakhine's extremists in Pakto Township, Arakan. Due to travel restrictions, no emergency medical service was received. Infectious disease is a major threat in Arakan state, and particularly in IDP camps. Lack of infectious diseases control is another fatal factor for Rohingya. Lack of health service provider, MSF, have increased the drug-resistant infectious diseases such as malaria, hepatitis, tuberculosis, dysentery among Rohingya community. Poor sanitation and lack of clean water in IDP camps increase waterborne diseases. Hepatitis and its complication, which is liver cirrhosis, are at the alarming rate. Intrauterine growth retardation and intrauterine death are very common among Rohingya in Arakan. Usually, HIV or AIDS cases were very low among Rohingya community, but it is also increasing due to unsterilized medical equipment, especially needles used by the Rakhine's medical staffs. Some HIV infections are results of gang rape by Myanmar military forces on Rohingya girls. So I will show you some pictures again. This is a girl, 3 months old, died due to fever and diarrhea in IDP camp in Pakto, Rakhine in 2014. There's another child with a skin infection, also in IDP camp in Sitwe in 2014. And here's another one, 54-year-old Rohingya man in IDP camp from tuberculosis. Due to restrictions of movement of Rohingya and with no foreign medical NGOs, it is challenging for health workers to reach out to the children, especially under 5 years of age, for vaccination. Significant increase in incidence of vaccine preventable diseases like measles and rubella. Maternal and neonatal tetanus are widespread, though it can be prevented by simple vaccination. Poliomyelitis, complete eradication has not been done in Rohingya IDP camps. No integration of immunization at the delivery level with infected hepatitis and HIV's mother. There's another, a state is sponsoring prosecutions on Rohingya since 2012. There's a drastic increase of depression, post-traumatic disorder among Rohingya population. Rape victims and the family members are stigmatized, isolated, and there is no formal counseling nor receive justice. In a single village, Bagona, Mangdo, 22 women have been raped by security forces in June 2012 alone, and one of them was my auntie. Victims come to death due to internal injuries as well as of trauma. Hospitals don't admit the victims so that they don't have to issue many medical reports against members of military. Rohingya children are being brought up under constant fear, intimidation, and stigmatization, which are fueling factors towards full-fledged genocide. So I'm going to show you just a very quick picture. This is a Jamila Khatun, was gang raped in 2014 in Baudupa IDP camp. There's another lady, several rapes by Burmese forces against Rohingya in 2014. So let us go and have a look at the poor records, healthcare records. The national average of doctor-patient ratio is 1:700 and 800, whereas for Rohingya is 13,000. We might not agree with Dr. Saad, but we will talk about it later. Maternal mortality rate is 380 deaths per 1,000 lives birthed in Mangdo Township, which is double of UNICEF figures. Under 5 years mortality is 135 children per 1,000 compared to 77 children national average. 5,000 pregnant women live in IDP camps who should receive regular checkup and access to hospitals, clinic, but they don't have access as per UNFPA. 40% children under 5 years suffering from diarrhea. Malaria and complications of hepatitis are the major causes of death and illness of Rohingya adults and children. Average life expectancy in Myanmar is 64 years old, whereas for Rohingya is much lower. Unfortunately, now many do not even reach 55 due to lack of medical care, starvation, or Rohingya men picked up at night and never returned back home. So I'll show you just one picture. This is the makeshift pharmacy in Sitwe IDP camps. What I wanted to say that Burma has marched to democracy, and again Rohingyas are left out. Aung San Suu Kyi has been giving indications that she needed some time to still the rolling waters of national politics, but now she's finally gave up to the hands of ethno-religious bigots. The only remaining hope for the Rohingya community who are suffering within Burma is the international community. Thank you very much.
Thank you, Dr. Ambia Parveen, for a very graphic presentation. I hope we will have questions and comments from the audience. We have 15 minutes, so please raise your hand, and when you take the floor, please introduce yourself so that the audience, not just the audience here, but the audience on the internet also recognizes you. Somebody want to talk?
Yes, I can please. You can hear me. One question to you is of the right of the political, because some sources say most coming from the Bangladesh. You say that 30,000 people are they only from Rohingya, or they are only from the Burma? So one question.
That's a great question. So the United Nations does not differentiate in terms of the identity of those who are coming from the Myanmar-Bangladesh border. And so the figures that we have shown are for both populations combined, because we do not have figures that will differentiate the identity. In fact, just identifying a person who is a Rohingya because of lack of identity paper in itself is very difficult. Yeah.
I just wanted to ask a follow-up on global. So if the UN figures are not identifying.
Could you just introduce yourself?
My name is Matt Schisser from the University of Michigan. So Boba's question, the people who are in boats in the Bay of Bengal, your answer is they're not identified. Are the points of departure from the boats identified clearly? So can we disaggregate the figures based upon boats that are leaving from Rakhine or boats that are leaving from Bangladesh?
A very good question. So both populations, so the overwhelming majority, even if you look at the UN data, states that these are predominantly Rohingya with some Bangladeshi individuals. The point of departure from the Myanmar-Bangladesh border is both populations. You have to remember that the country with the largest number of Rohingyas after Myanmar is Bangladesh, where they are devoid of many rights and the right to work. If we wanted to actually, did I not get your question?
Well, now, if both Bobo, you said you can't decide, you can't identify the people who are in the boat as Rohingya or Bangladesh.
That's right.
So I'm wondering if we can get an idea of who is in those boats based upon where the boats are leaving from.
Right, right. So, so as I'm saying, there's a sizable population of Rohingya in Bangladesh. It is the world's largest population of Rohingya outside of Myanmar. And so the point of departure from Bangladesh does not mean that it's Bangladeshis who are leaving. It can also be a Rohingya. I think in order to have academic level data, the source has to be extremely reliable. And so even though the UN reports say that the predominant number of arrivals when we ask them where they're from are Rohingya, we cannot ascertain that. So a lot of this data is going to come out in the form of a 4,000-word paper in the journal Lancet in about 3 months' time. And in that, what we will present is United Nations High Commissioner on Refugees data where they have ascertained the identity of arrivals and who they are. And so that, in my mind, is the only academically robust way of providing a compelling, convincing case on what is going on with these departures.
While we wait for questions, I have a comment. The latest estimates of Rohingya refugees in Bangladesh put them between 200,000 to 400,000. Now, I understand there are sizable Rohingya communities also in the Middle East and in Pakistan.
Yes.
And it may well be that some of them are larger than those in Bangladesh, since we don't have enumerated population.
In fact, I was just talking to Kusheen because I have, in writing this Lancet paper, I have reached out to Rohingya communities across the world, and the numbers widely range from 4 million to 400,000, and I am absolutely convinced there are extremely large populations in Saudi Arabia and Pakistan. However, there is no government data, no large-scale NGO data, and so we would in our table 2 for this Lancet paper, we simply put a star there and say that there are sizable populations in Pakistan, Saudi Arabia, and neither nation releases data on how many there are.
Good.
My name is Ronnie. I just want to make a comment there. Usually the water flows from a highland to a lowland, and immigration happens when there is an opportunity for a better life. So the question of Bangladeshis coming into Arakan state in this era or in this last 1 decade is in itself doesn't make any sense because there is nothing there in Arakan that could be identified as being a better life than the other side.
I completely agree.
I was just wondering if you have any visions for how improving penetration to the IDP and refugee camps could be achieved. Do you see bottom-up activist solutions as part of the picture, or do you see more of a top-down approach? Do you have any prescriptions for moving forward to address some of the deficits that were described over both your presentations?
We have a very bad documentations, and we need to document a lot. And then beside that, the awareness that we are doing is one of the main thing that then we'll know. With the awareness, we will know what is needed and how is needed. Of course, we need to pressurize the government. We need to not only on depending on there are a lot of universities, experts and all that they have visited, And they need to go with the Rohingya people inside, not with the Rakhines or with other ethnic people. Because the translation that they are doing over there, or their information that they are giving, is not the same that we Rohingya are actually suffering over there. So as I've said, we need more documentations, we need to pressurize the government. Awareness of you people will be also one positive point to go over there, and the government should allow the NGOs and the other non-NGOs to penetrate inside the country, and we need to really meet the people who are really suffering, not the ones who are on the borderline or who are outside the country, but we need to get the proper treatment or the proper help to those people. We need to go to the suffering people inside the Arakan, and especially the Rohingya.
Visiting the International State Crime Initiative. Ambi, I just wondered if you could say a little bit more about Doctors for Humanity that you mentioned. It's probably a follow-on from this question, but how do you do your work and what kind of support do you get, and how does that work, this coalition of Rohingya doctors?
Actually, it might not be for some experts, especially the medical experts, it's not the right way to help the people, because usually a doctor needs to have a contact with the patient. But since we cannot go inside the country and our people were suffering, a lot of cases were coming and dying. The simple cases were just a child had a fever or with a dehydration died. So we, in those 2012, after this violence, and in 2014, when the MSF was suspended, we wanted to help our people. So what we did that, when MSF was over there, they had some assistants, the Rohingya people who were helping them. So they were the one who was communicating with us through the WhatsApp. You know, media is helping a lot these days. So they used to put the cases and the pictures and the videos and the audios. Depending on those things, we were helping them. We don't have that much, I mean, we do the only advices and the consultation. We don't have anything to do with the donations or the funding and all those. But there was a group inside in Arakan, it was also a Rohingya group, volunteers who were donating some money so that whatever advice or the consultations we give, that they can give in to these patients and they can get the treatment. Yeah.
This is Laura Haig from Amnesty International. I wanted to thank you both for your talks. And I wanted to pick up this point on access to healthcare in Rakhine State itself, particularly in Rohingya populated areas. And you obviously discussed, or you referred to access to qualified health professionals, the number of doctors available to the population, in addition to obviously movement restrictions we're aware of. So I was wondering if you could maybe just talk a little bit about how that lack of access, whether it's material or it's barriers in terms of physical barriers, can create an environment where people have to leave Rakhine State in order to seek medical attention, medical assistance, and whether or not you have any figures or data on the numbers of people that have to leave for medical reasons, their ability to come back, but maybe also the types of health concerns that are causing them to leave. Thank you.
Well, it is a very difficult to say that how many people left and how many came back. It is really very, very difficult. But there was last year, as I've heard, that due to there were some cases in Sitwe and Arakan State, that the people have given the excuses, the Rohingya people have given the excuses that they are sick and they have traveled to Rangoon, the capital of Myanmar, and then they never came back. They were seeking for some, for some better life, which is not true, because most of them, they went over there, they died, or they never came back, and most of them even could not process this process going to other cities, because of the restriction, not only the restrictions of movement, but because of also the bureaucracy that they have to file, and also the financial, where will you get the money? You have to bribe here, you have to bribe there. So it is very difficult to say that, and we need more documentations. We need to do a lot of work. Myanmar is, we have to do not only the doctors, we have to do a lot of improvements over there. And as I've said, to get the improvements, you need to have the real sufferers. We need to talk to them.
From the Economist newspaper. I just wanted to ask you, what's the difference, if any, between the healthcare and other services in the IDP camps now and the rest of the state in general? I guess what I'm asking really is, does living in the IDP camps confer any better treatment in terms of healthcare now? Or did it in the past, say when they were set up 3 years ago, and it's since deteriorated, which I think is what some people say. But I could just, if you could just talk a little bit about that difference between Rohingya in the camps and not, and also what's happened to the rest of the healthcare in Rakhine State since, and particularly Sitwe, since the ethnic cleansing of 2012. I mean, there's been so-called a lot of development in Sitwe, which I've seen from my own eyes. Has that gone into healthcare? Has healthcare improved at all in Sitwe? A lot of UN agencies working there now.
Recently, I have read one in March, one photographer, I don't exactly remember her name, she has visited the IDP camp in Sitwe. And according to that, yes, the NGOs and the non-NGOs, they say that they are working inside the country, especially in the IDP camps. But most of them, they said that 24 hours, one of the, I don't remember exactly which NGOs, that it was working for 24 hours and 7 days per day. But she has noticed that there was nobody there. The office was open, but nobody was there. And also the other NGOs, you hardly see them. So this is just one picture I have shown, a lady with the jaw and the mouth cancer. She was suffering there in the Sitwe camp for 2 years, and this lady has been, the relatives have been trying to talk with the UNHCR and the NGOs, the people who are responsible inside the camp, but she never got the treatment. She never got even the permission to go to another city, to Rangoon, to save her, What I understood, what I heard also from the interview is that this has started only 2 years with a small ulcer, and then it has become bigger and bigger, and it could not be prevented. What is my conclusion is that there is no betterment or betterness within the IDP camps and near to the IDP camps. After the 2012, the MSF left, the things have worsened.
And I should just clarify that so MSF did come back 9 months later, but is very, very, in a very subtle way, is trying to be under the radar. And part of the reason that they left, temporarily speaking, was that they, with Fortify Right, Matt Smith's organization, Fortify Rights printed a report which was very critical of what was going on with a lot of data from MSF. And these IDP camps, I refer to them as, if you might notice, IDP containment camps, because that's what they are. There's no free movement. There's also several thousands of Rohingya living in their own villages who are not in IDP camps, but are surrounded by hostile neighbors, and humanitarian agencies have not been allowed to access them. So essentially, there is no healthcare. Barring this very fragile MSF presence, which any day could disappear.
We have to bring this to an end.
Sorry, we have to close this session.
Can I just finish up? Thank you, all the speakers and the audience, for your questions. We've discussed in this session issues related to the consequences of political disenfranchisement, and we've seen how malnutrition and disease and lack of healthcare also leads to death. So we're talking about genocide in terms of slower processes, and I think this epitomizes the notion of structural violence. Thank you.
So